Good evening, ladies and gentlemen. This is Dr. Paul. Thank you very much once again for tuning to this channel today. Let me talk about ACE inhibitors today. These medications, they inhibit renin-angiotensin aldosterone, and also they inhibit the degradation of bradykinin. And they have compelling indications, especially in patients with diabetes mellitus, congestive heart failure, and chronic heart disease. Also in patients who have had a myocardial infarction with systolic dysfunction. So these medications, angiotensin converting enzyme inhibitors, ACE inhibitors, they reduce disease progression in patients with renal disease, especially African Americans. That's what we have seen in ASK trial. But in ALL-HAT trial, we have seen that ACE inhibitors, they increased the risk of stroke in African Americans. So that's an important thing you need to say. In African Americans with renal disease, they are extremely useful, and on the other hand, they increase the risk of stroke in some patients, especially African Americans. That's an important difference we need to say. Now, they stimulate nitric oxide. That is how they increase the vasodilation. You say most of this blood pressure comes from vasoconstriction. And as vasodilation happens, the peripheral resistance decreases, the afterload decreases. And as a result, we have this decrease in blood pressure. Now, enalapril, captopril. Let me talk about enalapril. Enalapril, it is a oral drug, and it is converted into enalaprilat in the body. So enalaprilat actually useful as intravenous use, primarily for hypertensive emergencies. When blood pressure shoots up higher and higher, enalaprilat is very useful. There are other medications, benzapril, fasenopril, moxapril, perindopril, quendapril, lamipril, and tradalopril. These are all ACE inhibitors. And all of them are prodrugs like enalapril. Prodrugs means they are converted to active agents by hydrolysis, primarily in the liver. So ACE inhibitors, they need liver for their action. That's why in liver failure, ACE inhibitors don't work. And chronic kidney disease, they are extremely useful. Why? Because ACE inhibitors, they reduce proteinuria and they stabilize the kidney function. That's the use, and the benefits primarily result from improved intrarenal hemodynamics with decrease of glomerular effect. I mean, the arterial resistance decreases, and the resulting reduction of intraglomerular capillary pressure is the what happens actually with this medication. So the intraglomerular pressure is decreasing. And also after myocardial infarction. So we have this evidence. They reduce the incidence of diabetes. I mean, in patients with diabetes, they reduce the incidence of cardiovascular disease. So that's a very important point right there. So in patients with diabetes and who have cardiovascular disease, think of these medications. All of these medications are eliminated by kidney except fasenopril and moxapril. So in kidney insufficiency, renal insufficiency, we are calling acute kidney injury nowadays, these medications should be decreased. Now, they cause some side effects. The most common adverse effects we see, they include this acute renal failure. Some patients might get acute renal failure, particularly in patients with bilateral renal artery stenosis. So when there is stenosis, or if there is just one kidney and that stenosis is there, these medications are contraindicated. And also they cause wheezing, cough, and angioedema, and hyperkalemia, the high potassium levels in the body. So that's an important point right there. So angioedema is a life-threatening side effect. So the patient, that's very important to ask. Some patients will get angioedema and it's a life-threatening complication. So you need to avoid these ACE inhibitors in patients who have this problem. And sometimes, now the other complications, especially in pregnancy, second and third third trimester, there is evidence that these ACE inhibitors causes fetal malformations, anuria, hypotension in the baby. That's why we should avoid these medications in pregnancy. Also in patients with renal insufficiency, they cause neutropenia or proteinuria. So those are the very, very important. So first trimester, second trimester, third trimester, irrespective of it, we have evidence today that ACE inhibitors are not good in pregnancy, so we should avoid them. Now, important drug interactions are with potassium supplements. I said ACE inhibitors, they increase the level of potassium in the blood. That's why you should not give them any medications that increase the potassium level. For example, potassium sparing diuretics like spironolactone, amiloride or triamterene, you should avoid them because hyperkalemia only gets complicated, and also hyperkalemia also happens with potassium supplements. For example, you are giving Lasix and potassium chloride to a patient, and when the patient is admitted, somehow you stopped them on Lasix, and then you started to give them ACE inhibitors like captopril, and the patient will go into hyperkalemia and sometimes heart stops in diastole because high potassium level is a life-threatening condition. So every time you start these patients, you should stop potassium supplements unless indicated by other diuretic use like Lasix. So the main points are ACE inhibitors, they have proven to be very effective in heart failure, in chronic kidney disease and after myocardial infarction, and also to reduce the risk of cardiovascular disease in diabetic patients. And they are all converted into their active forms by the liver, and they are primarily excreted by the kidney. They are contraindicated in pregnancy. They are also contraindicated in patients with a history of angioedema, and their main side effects are dry cough, angioedema and hyperkalemia. Those are the main side effects. And except those things, these medications are wonderful medications, and we are reaping the benefits, and these medications have compelling evidence to use them in the practice. Thank you very much and have a good night.